Now, we have a very important panel discussion on a burning issue today, that is future of medical education in our country. As you all know, lots of things are happening in the field of medical education in the country. Starting from 3-year diploma course in West Bengal to, I heard that there are 9 professional exams in UP. In our time, it was only 3. And then inclusion of alternative medicine or this Ayush medicines in the curriculum of MBBS course. So lots of changes are happening. And we seniors as well as new graduates and those who are entering into the medical course, they are all worried about the future of medical education in our country. Another big thing is that medical colleges are mushrooming all over the country. The government aims to open 1 medical college in each district of our country. Now, if there are so many medical colleges, from where they will get faculty, from where they will get infrastructure. Already, as you know, there was criteria for starting a medical college, and a very strict criteria which was followed by the Medical Council of India. That has been changed. Now it's being reduced. We are afraid a time may come when in a 3-bedroom flat, 1 medical college may be started. So it's a, worrying future of medical education in India. And we have a panel discussion, and we have eminent debaters in this panel discussion. I invite Dr. Krishnendu Mukherjee, who is the moderator, and he will invite the panelists. And I hope that you will hear a very lively discussion on this subject, future of medical education in our country. Thank you.
Ladies and gentlemen, good evening. Sincere thanks and regards to the organizers of the conference and to Dr. Dubey for conceptualizing the need for this panel discussion. Dr. Sarkar said that he announced the scientific session comes to a close. I think by default, therefore, it means that this panel discussion on medical education is not scientific. Anyway, we have a galaxy of panel, and it's my honor and privilege to invite them, and I'll give a short introduction for each of them. Professor Dr. Pradeep Kumar Mitra, please. He is now the medical director of Gauri Devi Medical College in Durgapur, but we know Pradeep for many years. He was the former director of medical education and director of SSKM. Professor Dr. Makhonlal Saha, again I have the privilege of calling him Makhonda. He was the former professor director of the Department of Surgery, SSKM, past president of West Bengal ASI, a very famous author of a very important book, and a teacher, and at present a visiting consultant in MR Bangur Hospital. Thank you. Professor Abhijit Hajra. Professor Abhijit Hajra is professor of pharmacology and is the Dean of Student Affairs for undergraduate, postgraduate, and postdoctoral courses in IPG MER. He sits on the ethics board of many medical institutions and has numerous publications to his credit. Professor Abhijit Hajra. Dr. Saurabh Ghosh, he is the medical director of the KPC Medical College and Hospital. He is a member of the Health Core Committee of both the Bengal Chamber of Commerce and FICCI, FICCI. But to me, Saurabh, on one side, is a surgeon. He's a member of the Royal College of Surgeons of Edinburgh. And on another side, he was the doctor to my mother. He treated my mother. Dr. Binayak Sinha, a very well-known consultant, diabetes and endocrine physician of the city, numerous publications to his credit, and even though he's involved in teaching in his own way, I have invited him to the panel because he had extensive experience of teaching undergraduates and perigraduates during his time in the UK. Ladies and gentlemen, I would request you to give a big hand for the next panelist. We are talking of medical education. We needed to hear from a medical student. We have Dr. Sanjeevani Hajda with us. Please. She is a fresh medical graduate and now an intern in SSKM. She was the academic secretary of the South Asian Medical Students Association and an international ambassador of the special study group, Neurology and Neurosurgery Special Study Group of United Kingdom. Thank you very much, Sanjeevani, for joining us. Right, now we have about 45 minutes time. I'll be visiting each panelist with a question for about 5 minutes, and then if we have time, we will return back to them and try and ignite the panel discussion a bit more. I'll first go to Professor Pradip Kumar Mitro. Sir, can you tell us in a nutshell what really has changed in the last 10 years and why there was a need for this change? If there's a change there, a need must have been felt. So,
very difficult to, give in a nutshell. Anyway, thing is that why there is need, you asked.
And yeah.
Yeah. Actually, here most of the doctors I see they're grey haired mostly. So naturally they can understand that we have passed, and every time we boast about that. In our time this was this, this was this. We studied anatomy for 2 years and dissected bodies, every parts of the bodies, every tweaks giving to the different areas. But later on, you also realized that what's the actually need of knowing so much of things for the undergraduate students, anatomy, particularly I am starting from the first subject, anatomy. Definitely we'll have to know the basis of the major arteries, veins and all this, but what's the importance of those who will go for the postgraduate studies, you will understand that. So gradually, what is the basic idea? What idea was to produce a basic doctor who can diagnose and treat the basic diseases, most of the diseases. So in course of time, it has been felt that the basic doctors are lacking. Though actually objective was that, but outcome is not that. So usually we make a thing that is the input process. In the educational process also we can put this. That is the input, that is the one process, then output and feedback. So the students are entering the first year, and through a process of medical education they are coming out, and ultimately output means basic doctors. And the feedback is what? They are going to the rural areas, they are not being competent enough to see that patients and the different health needs. And they fail to communicate with the people also. So gradually things are changing, and then MCI also thought, now NMC was thinking that there must be some change in the education, that they must be exposed in a, prior to clinical exposure, they think they should be exposed from the first year to the clinical side, to the families, they should visit some families. So that's why, and they are some weak in the language English, so they thought of some foundation course, and in that course they should know some medical history. In this way, that the idea came that there must be some change, and the duration of the course has been reduced to 4.5 years. Actually, what I think Abhijit will tell about the NMC programs and what is going on recently. I'm not touching that right at this moment. So I also think there must be some change so that we can produce the basic doctors and who can serve the country. Particularly, the rural areas are more than the urban areas, so they can serve the country in a better way. So this is the need. So later on, if you I can get chance, I can elaborate further.
Okay, thank you very much. Professor Pradeep Mitra has completed in about 3.5 minutes. I'll skip Professor Makhonlal Shah. I'll preserve him as a machine gun for later on. Professor Abhijit Hajra, can you tell us again in a nutshell, in about 5 minutes, what are the important changes introduced by the National Medical Commission in undergraduate teaching?
Okay, thank you, Dr. Mukherjee. The most important change is that now every medical student realizes that we have a regulator. In its earlier avatar, it was the MCI, the Medical Council of India. But the earlier generations of students like ourselves were hardly aware that there is such a thing as MCI. But now, the regulator is the National Medical Commission, and Sanjeevani and her immediate seniors and juniors, every day they are reminded that there is a thing called NMC which guides their fate and destiny. So beginning with 2019, there has been a lot of changes. There has been a complete revamp of the curriculum. It has been organized as a competency-based curriculum. And starting with every discipline, competencies have been numbered and defined. So this is a major change, and this has all been made publicly accessible. So every stakeholder, be it a student, be it a parent, be it a teacher, knows what exactly is expected of now the term that is being used is Indian medical graduate. And they're using it very proudly, Indian medical graduate with a standing in the world of medicine. Now, the last major revision of the curriculum, I'm speaking about the UG curriculum, was in 1997. That's in the last century. Okay. There have been piecemeal changes, but now we all have a document which was released just a few days back on 12th of June this year, where they have systematized all the changes which have been made so far and which are in the offing. So I'll highlight a few. Curriculum has been revamped. The distribution of the phases through which the student has to pass, that has undergone repeated revisions. When we started our teaching career, first MB used to be 1 year, second MB used to be 1.5 years. We had third professional part 1 for 1 year and third professional part 2 for 2 years. As it stands today, first professional and second professional would be 1 year, third professional would be 1 year, and the final phase, third professional part 2, would be 1.5 years. Okay? Subjects remain in the first professional anatomy, physiology, biochemistry, but side by side, you have a community outreach in all the phases and a new element modeled a little bit on the American system of early clinical exposure, where even a first-year medical student is expected to tie up with clinical units and at least during the admission days be present in the wards till 6 p.m., learning what happens. Of course, not taking any independent decisions or doing any independent things, but being there under supervision. So this is being called clinical clerkship or early clinical exposure beginning with the first year. Although how it would be implemented, that is a major question for us. The next major change is that community medicine, exposure to the community, is becoming all prevalent. So right from first year, where you start some of the theoretical exposure to the community, then from the second year onwards, students are expected to follow something called a family adoption program, where they are in the outreach areas of the concerned college. They have to adopt families and be the early points of contact and visit these families at certain intervals and generally be in touch and help in the management of chronic problems in this family. So this is being called a family adoption program, being spearheaded by the community medicine departments, and this would last throughout the duration of the MBBS course. In the second year, they'll be learning microbiology, pathology, pharmacology. Forensics has largely been shifted to being a clinical subject. There is some bit of forensic lectures in your second professional MBBS, but most of it now will come in the third professional MBBS along with community medicine. Now, for a long time, eye and ENT used to be part of third professional part 1, but very recently they are now again being shifted to third professional part 2. Structures of internal assessment examinations and university examinations have been changed. I'm not going to burden you with details, but the most important change in the offing, which is still evolving, is a thing called the next examination. So we are all waiting for the picture to become clear. So your traditional third professional part 2 university examination would be replaced by a nationwide next examination, which would be held at least twice every year. This will serve as the exit examination for the MBBS course, as well as an entrance examination for PG courses. Exact modalities are being defined. They will become clear as time goes on. So, a few more things are there. In order to provide students with an exposure to some areas beyond their routine set curriculum, a system of electives has been introduced, injected between third professional part 1 and third professional part 2. So they have to spend 15 days as a block 1 elective in pre and paraclinical disciplines, doing something of their choice which the college offers. It can be as a research project, or maybe it would be in the blood bank, whatever it is. And this would be followed by another block of 15 days where they do something out of the routine in association with clinical departments. So overall, a lot of changes are happening, a lot of experiments. My personal view is that these experiments are going on without a control group. So only time will tell whether we produce more competent and better doctors than what we have been producing so far. So we all look forward to the future.
Thank you very much. Thank you very much. Once again, in just 6 minutes, that was a very nice nutshell. But just to clarify, Professor Hajira, for the audience, 1 year, the first year would be the first professional MBBS, anatomy, physiology, biochemistry. Second professional MBBS is 1 year. That will be microbiology, pathology, pharmacology.
Plus your clinical subjects, wards and all start from the second year.
And after second professional MBBS, that's 2.5 years more, because it's 4.5 years. These 2.5 years will be divided into 2 final professional MBBS, where IENT comes later.
Yeah, at present, they are coming with third professional part 1.
Okay.
But now it is proposed with a new batch.
Okay.
I and ENT would be coming with medicine, surgery, and gynecology examinations.
So I think now all of you have got a reasonably good picture. Now, before I come to perspectives of private medical colleges and perspective of a student, I'll go to Dr. Binayak Sinha.
Just with your permission,
yes,
just
please.
one point.
Yes.
This is for the Ovijit. Have you seen that recently on 23rd of June, NMC again put a...
23rd June, they put out guidelines for establishing a new medical colleges. And the most interesting thing that they're stopping 200 and 250 seats colleges.
Yes.
Maximum 150
Maximum
seats.
150. They had realized that...
Just to add, today afternoon at 3 o'clock, NMC has given another amendment to its existing curriculum that has been proposed by them. And that is totally in contradiction to what they have proposed and what
Earlier.
Professor Hajra was
Okay.
saying.
That's
So-
why I'm telling
It has come
us.
at 3
Okay, I
o'clock
think
this
sparks have started flying, and that's healthy, that's good. We'll come to you, Saurabh. I just specifically wanted a perspective from Dr. Binayak Sinha. Again, in about 5 minutes, can you tell us in a nutshell a comparative analysis, a comparative study of the way things are going in India vis-a-vis a few developed countries and a few emerging market countries?
Thank you. Thank you. If you'll indulge me for 1 minute,
Yeah,
I'd
sure.
like to bring up what Dr. Dubey mentioned. You know that medical colleges are springing up so much that next they'll be in 3 BHK. And this has a precedence. This happened in Malaysia.
Okay.
In Malaysia, they had so many medical colleges mushrooming and so many medical students coming out as doctors. They finally had to do a rapid culling and cancel the registration of a lot of doctors who had qualified from certain medical colleges, and things had to be laid out properly. Now, I think what India needs to learn is some things from the West and also from some of the developing countries like we have in Indonesia, Malaysia, Thailand, etc. I find the Indonesian model very nice. First of all, let's start at the very beginning. This examination system through which you come in, you are just checking the person's ability to learn by rote. This is dangerous. A doctor is not about just knowing the subject. A doctor is about a man with an attitude. He has to have a particular behavior. He has to have a particular psyche. He has to be able to be in empathy with the patient. So this is not just done by studying in a medical college, and there is a personality aspect to it. Now, as you know, in UK, they go through a very rigorous interview process, wherein not only are they testing your biology knowledge or your knowledge of basic science or something like that, they're also testing your psychology. They're testing your ability to be empathic. They're testing you as a human being. This has been brought very beautifully into the Indonesian system. The Indonesians, not only do they have a result-based things, you have to do your biology, physics, chemistry, and mathematics and get certain grades to qualify for the interview. There is a very strong interview process which goes into selecting a medical student, as well as a strong psychological and psychometric assessment. Because, it is no point going into medicine. I have seen a lot of things, Today we discuss a lot of things about, patients being angry with doctors behavior being not nice. And the main reason for that, I feel, is people have come into medicine without realizing what is expected of a doctor. And that can be ruled out by following these kind of systems. Also, the American system is wonderful in the sense that, you come into medicine when you've grown up a little bit. At the age of 18, the amount of maturity a person has, the amount of ability to think out of the box or make a lifetime decision, I feel is very low. So an American graduate actually starts doing medicine at the age of 23, when they are slightly more mature. They have done an undergraduate course, and that might be even core humanities. They can have done something in English and then decide that I want to go into medicine. So this is the kind of things that are going on in the rest of the world. But finally, I think we need to make a decision, as Bertrand Russell said, educate a person thinking what the result will be. So I think we need to think what kind of doctors we need in our country, and I think we need primary care physicians. People who will look after people in their homes, people who will be able to treat people with Hachi Kashi Shoddi. This is what we need. We need a good program to enable that. Whereas our programs till now has focused on high-flying, evidence-based, high-flying medicine, knowing serious cardiac workup, serious surgery, which is not the need of the hour. So I think there is a lot to pick up from the models that there are in the West, as well as from developing countries. And I think if we manage to invoke and bring into the curriculum these kind of modalities of selection as well as teaching, then I think we will find that our system will also become a success. Thank you.
Thank you very much. So Dr. Sinha reflected what Professor Pradeep Mitra said, and basically both of them indirectly have told us, all of us, that we are not basic doctors and we have not treated people thus far. Incidentally, the interview that Dr. Sinha told you about, in the UK, the multiple mini interview system has not only been introduced, it has been studied and it has been validated. So it's a validated method of taking in candidates for medicine. I'll go to the student now for a student's perspective, and it is Dr. Sanjeevani Hajra. Just to remind you that she was the academic secretary of South Asian Medical Students Association and international ambassador of Neurology and Neurosurgery Special Study Group of UK. She is passed out from SSKM just 1 year ago. Tell us in about 5 minutes what you felt and what you feel.
Thank you, sir. I joined my MBBS in 2018, so I started my internship this year. The throughout these all years, the vastness of the thoroughness of the syllabus has quite mesmerized me and scared me. But it has, more than that, it has provided me with a lot of new things to learn, to new concepts to learn and new skills to learn. The second and the final years were quite the highlight. Second year because our clinical classes started for the first time, and final year it was the year after COVID-19 we got to attend the face-to-face classes again. I especially liked attending the evening classes that our professors and seniors stressed upon, because we got to learn things in a much more, with an ample amount of time which was not quite possible in the morning scheduled class of 2 hours. Somewhere under the mentorship of a resident senior. I sometimes think that such a mentorship program we would have liked being part of such a program since quite early in the course. Now that I'm in internship, I'm realizing my procedure skills to be very deficient and very poor. Hardly a few of us in our batch knew how to draw blood or do a intravenous cannulation. Slowly we are all learning, but we take a lot of time at this point to do one of those procedures. And when we need to do them faster, we cannot do that. Also, sometimes it has also happened that we go to do one work, which one person can do, but we are going as a group of 2 to 3 because we are not confident with our skills. I sometimes feel that if we had been taught, if we had learned these procedures quite earlier and continued with regular practice, it would have been much more helpful, both from the perspective of the patient care as well as from our perspective, the difficulties we are currently facing. There's one more thing, one more serious point to note is that the very poor attendance of students in lecture classes. I inquired my friends regarding their reasons why they didn't attend the classes. Some said that they couldn't understand a few classes well. A few others felt that the lecture classes were more of a one-way interaction and they lacked some sort of intellectual challenge, and some lacked motivation. However, what I felt most acutely was the high student-teacher ratio. We acutely felt the very low interaction between our professors, our teachers, and our students. Sometimes we found it difficult to approach our teachers regarding doubts, and we feared being ridiculed by our peers. Sometimes we realized the time constraints posed by a larger group of students and a relatively shorter amount of time assigned to each class. Also, sometimes a few hesitated due to a perceived lack of encouragement. But I think that sometimes there was also, I attended a few classes with very poor attendance, and I think I learned better in those. There's one more thing that I got to learn recently when I interacted with a few medical students from other countries, that I don't know quite a lot of things that they do know regarding certain procedures, methods they have learned, or certain new technologies, and I wish to learn them. And I think that we, the current and the next generation of Indian medical students, we would need additional skill sets to keep pace with the advancements in the field of healthcare as well as lead greater developments in it. Some of the few things that have interested me quite a lot are programming related to database, data sets, healthcare data, as well as like data science tools, and working experience and result analysis with the new instruments that are currently used, like high performance or high pressure liquid chromatography, mass spectroscopy, or newer developments in microscopy. I was also intrigued by medical ethics and legal issues, which was touched upon in our syllabus, but we couldn't go in more depth. But one more thing that was like that in our third and the final years, it felt that we rushed through the whole 2 years very soon. Probably it was because of the COVID-19. As a result, we found very little time to understand the subject and go deeper into both its theoretical and practical aspects.
Okay.
But despite everything, I must say that I am enjoying every second of my training. I'm enjoying it a lot, and
Thank you.
I'm very much thankful to be a part of something where I think I can do something. Thank
Great,
you.
thank
Thank you
you.
very much.
So it was
Yes,
really nice.
Dr. Mukherjee,
really-
just if you allow me, just
Yes.
following on from what Sanjeevani has said, this acute lack of confidence in the students who are passing out and becoming interns and junior doctors is also reflected in NMC's current way of thinking. So I forgot to mention it. NMC has made mandatory provisions for skill labs now in all the colleges, and a provision of an 8-com module. They have spread it out of the 3 years, both with the idea of building up procedural skills as well as communication and soft skills.
Okay.
So those have been given a lot of emphasis. Another thing which is given emphasis is that students are being told that everything cannot be taught in medicine. So a large component of so-called SDL, self-directed learning, has been introduced. The number of hours have been defined, but the problem is how do we motivate the student to do that?
Okay, great. Thank you very much for the addition. So, Dr. Sanjeevani Hajra, as we welcome her to to our fold, it was a very, very honest submission that where she lacked she and her peers lacked confidence at the beginning of internship. She felt that there were more students compared to teachers. Thank you very much. That was very good. We come to Dr. Saurabh Ghosh now. You are the medical director of the premier and the first private medical college of our city, which is now doing very well. Please, your perspectives about these current changes.
Thank you. Before I go to my idea about the medical education that we are following right now, I would like to ask you one question. At which point of your student life you learned to introduce a IV cannula?
I think around 30 or 40.
Exactly so. We also had that experience in the emergency. While we were doing our emergency duty from third year onward, there was no CBME, there was no skill lab. We had enough patients. We have our seniors who were eager to teach us how to dress a wound, how to put on a bandage, how to put in an intramuscular injection, how to put in a intravenous injection. And we were all running after them. Please give us a chance. I'll do a LP. I'll do a IV line. I will start the IV fluid for you. And they never refused us. So what he was discussing a few minutes back, this psyche, this, the heritage that we had in all the medical schools previously, which is, I feel we are lacking in most of the cases right now. Anyway, I'll come to that later on. Thing is that regarding the medical education, as Pradipda was briefing at the very beginning, there was an urge to change. Now, who said that there was this requirement was there to change something in the medical education? There must be an expert group who has worked on that. So who were the experts? We do not know. What were their credentials? How many hours they have devoted in medical education before coming to that expert group? Did they held any meeting regularly? Where are the minutes of those meetings? Before
Can I just interrupt you for 1 second? I do not know the answer to your
No, I'm
question.
just coming to the main point.
Yeah, but NMC, the fact that MCI should be replaced by NMC, this work was done by a group of management trainees. There was not a single doctor in that group.
I cannot mention all those things here in the dais.
Of course you can.
But we all know, everybody is eager to bring in a change in the medical field. Have you ever heard somebody thinking of bringing a change in IITs? Have you ever heard there is an urgent need of getting some change in the legal field?
Yes, I know. Anyway, okay.
I'm just telling you, everybody is eager to modify the modalities in the medical field, the modus operandi of admission, the modus operandi of exit test, and the planning of new curriculum. But there must be some rationality. Now, coming to that, this expert group should have analyzed some data based on which they have come to their conclusion. What are those data? Like you were questioning a few minutes back, all the doctors sitting over here who have not gone through this CBME and other things, the skill labs and other things, they are all rubbish. They have not been properly trained. They have not treated the people of India. So we are thinking of somebody who will come and treat the people of India now. Now coming to this family adoption program, I was present in the meeting that was conducted by the health minister centrally, along with the experts from the National Medical Commission. They invited people from all medical colleges. Majority of them were reluctant to join that meeting, but incidentally I was there. We raised a simple question. I am sending first year student on day one to adopt a family. Now you consider it yourself. I am coming to your house, introducing myself. I am a student in a medical school. This is my first day in my medical college. I have come to adopt your family. Say around 9 o'clock in the morning, when you are rushing to the hospital, your wife is rushing for his office, your children are getting ready to attend their schools and colleges, and you will sit down with me, whose qualification is just higher secondary, to brief about your family to me. What a novel idea. What a novel idea. Why should you brief all these things to me? Your personal things regarding your family? Then they said, no, doctor, you send them to the villages, as if the people who are living in the villages, they are the son of the lesser god. If you and me have to start for my office at 8:30, they have to start at 6 o'clock to come to the city. And they have got enough time to entertain my students going from a medical college to adopt their family. And I have interacted with my students. I do it very frequently. We have this family adoption program from third year onward when they are attending the community medicine practicals, right? So they usually go for this family adoption from the year 2008, not today. But when they have gone to different families in South Chobbish Pargana, here in West Bengal, for calculating the Kapusami scale, they have asked somebody, we have come from a medical school, we are supposed to adopt your family, we have to maintain a, family folder. Please let me know what is your family income. You know what reply they got? Tumi ke, tomar kache amar badi rozgar bolbo. আমি খেতে পাই না পাই সে আমার ব্যাপার আমি কোটি টাকা রোজগার করি আমার ব্যাপার তোমার কাছে কেন বলতে যাব
Okay, so
and
you
now
think
this thing when we come to first year they will be elaborating everything to them. So the stakeholders, some policy makers, they are not accountable to anybody except their masters. We have to get some wonderful plan and place it tomorrow just to modify it day after tomorrow. As I was telling you, today afternoon at 3 o'clock, they have sent a notification that the proposed MBBS curriculum along with the family adoption program has been scrapped.
Okay.
That's
Till
why,
yesterday, it was a burden on us. You have to implement it right today. You have to send your students right today to the families. So are they guinea pigs? Regarding you are talking about undergraduate students. What about the postgraduate students? You are sending them for district residency program. Why? Who is training them? Say I am doing an MS in anatomy. Who will guide me in the district? How many expert anatomists are there? Say I am doing my microbiology, MD microbiology. Who is going to guide me over there? And you are taking away 3 months of my time from second year residency in the district residency program. It's very simple. We cannot manage to put a doctor in every health center. We are not in a hurry to adopt more doctors, to take more, employ more doctors there in the health centers. So it is the easiest way. You send the students over there and prove to your master, look, there are doctors in every health center.
Okay.
That is what they're doing.
Okay.
That is what they are doing. And the undergraduate students, I'm not talking about Sanjeevani. She was very honest in her submission. I'm talking about the average student. Don't go for the best one. Don't go for the worst one. I'm just leaving them around. You just consider the average medical student. they consider their undergraduate degree just a certificate to sit for the NEET PG examination.
Okay.
Nothing more.
That's again a very important point made. So thank you, Dr. Saurabh Ghosh. She has brought out a very few very important points. We realize now that the change was necessary, but as pointed out later, how those changes will come or what changes have actually come, they are not necessarily what we actually required. I'll come to Professor Makhonlal Shah, and that will be the end of this round, and I think we'll still have about 7 or 8 minutes after that. In around 5-6 minutes, Professor Shah, kindly tell us one thing. On paper, it glitters. Is it gold?
Can I have my
please,
slides
please,
for just
please.
5-6 minutes?
Please.
I start with Sanjeevani. She is a medical graduate that is running for long years. That the usual MBBS course. The points she raised are all valid points. And all these points are addressed by the new NMC regulations. If you go to the NMC regulations, you will find there are a lot of changes and they are really glittering. The points raised by Dr. Saurabh Ghosh, I agree that there are some loopholes in thinking, but if you go to the details of this NMC new concept, the concept of creating an Indian medical graduate, what is this concept? They're trying to say that we are training some brilliant students for a period of about 5 years, 4.5 years, plus 1 year of training, and we bring up some people who has acquired the knowledge, competencies, skills, and aptitudes that allow them to practice medicine professionally, ethically, at the highest level. And they should have some other career choices, not only treating patients. They should be in an open field where they can go to research, they can go to public health, they can go to leadership, management, or they can be pioneer in medical education. So it's not that creating some doctors who will go and treat malaria and treat the basic disease. There has been radical change. As Dr. Hajra has said, there has been a radical change in this curriculum, and this curriculum started in 2019. The first batch will be appearing in final exam in 2024. This timeline has been discussed, and you'll find this is a new introduction. And I can assure you that all the students who join this course, they have 1 month of fun. And that was the introduction to the MBBS course, where there are some boys coming from South India to Bengal, Bengal to some other place. There was a language barrier. In this 1 month, they are supposed to adapt to the local language. They are supposed to have an extracurricular activity in the form of sports. There has been session by psychiatrists at the entry in the first month to train them how to manage the stress of these 4 or 5 years of intensive study, exams. But you'll find that since it started, there has been a hit by COVID. So this has taken a back seat. Time was reduced. But it was a very welcome step that the students, before they start their MBBS career, they have a nice exposure to these basic things. And whole concept of MBBS course has been changed to a term called competency-based medical education. What is that? You create clinician, yes. They will be taught the basics of medical science so they can treat people with holistic care and compassion. We are creating a batch of graduates who can be leader, like Sanjeevani, who can lead the international forum also. So we are creating a leader. We are creating a communicator. You will find this new NMC has a new introduction known as ATCOM, Attitude, Ethics and Communication. Every subject has this component. You are not only teaching a hernia patient, you are not teaching a carcinoma patient. You are treating this patient and you make the boy, the student, have a separate way of communication. That was lacking. Everyone here has to realize when we are MBBS students, we do not have this part of interacting with the patient in the part of communication. No student ever has reacted or communicated with the patient relatives. This is a situation where students will be called and relatives will be called, and then in presence of the relatives, the teacher will counsel. Your patient has got a terminal cancer. He needs the treatment. We may not cure him, but he may be given some palliative treatment. So that is the way the student will be communicated. We are creating a professional. A student who passes out at the end of 5 years is not that he just will go and treat rural people. He should be a professional. And he should be aware of his professional and ethical part of his career. You'll find the new curriculum, the didactic lecture has been reduced to a great extent. More emphasis has been placed on clinical exposure. However, NMC has given strict norms that one has to attend 75% of this class. NMC has installed digital attendance in front of lecture halls. But you'll find that NMC wanted to monitor the attendance in Calcutta sitting in Delhi, how many students had entered into this classroom. So these are very welcome steps by NMC so that they can monitor, they can improve the standard of this education. See this class, it's a premier medical college in Kolkata. There are 250 students in the class. This is the highest attendance, 45. The average attendance is only 20 to 25, as Sanjeevani has said. There are various reasons, but that is the picture for a typical lecture class. This is a bedside class. It's a batch of 20 students, 15 students. You find only 5 or 6 are present. Even in the bedside class, they are not attending. There are something wrong in between what NMC is expecting and what is happening in the real field. A new trend by the medicos. They are more towards e-Marrow, they are more towards e-Gurukul, they are more towards online medical education sites. The NEET PG preparation starts in first year. Last week, one boy came to my house. He just qualified in NEET UG. The counseling has not yet been done. He just wanted to decide what book to read, how to proceed with the studies. The last question he asked me, sir, does the NEET PG preparation starts from first year? So that is the level of thought process. The boy who has not entered MBBS started thinking when he'll start preparing NEET PG. So that is a tragedy that we are not focusing on what is required in this initial 5 years. So I'm not going to details of this. What is the current scenario in India? There is tremendous number of medical colleges. And government is planning to have every district hospital to become a medical college. At the moment, in this month, the current MBBS entry is 1,04,000. NMC has got strict criteria for appointment of faculties, there are promotions. And there are huge deficit of faculties with advent of these new government and private colleges. Go to the private medical colleges, you will find in papers, there are a huge number of faculties. There are 6 professors, most of them are retired, and they are paid a very meager salary. I could find a faculty working in a medical college with a monthly salary of 15,000. I asked him, why your salary is 15,000? He honestly told me, I come once in a month. So that is the situation. In spite of such strictness, that is the reality what is happening in our medical field. NMC regulation says that there has to be a faculty development program. All faculties has to be trained to teach this new batch of students. But it is true that COVID has hampered this training program, but I can assure you, I retired 2 years back. I reacted with my colleagues who are in the medical colleges. I asked them, what change you made to teach the new batch? They said nothing. The same way you are teaching earlier, we are teaching the same way. But there would have been a radical change in method of teaching. So faculty development has taken a back seat, but I realize this will be again coming up, and I'm sure you need a good quality of faculties to adopt this new NMC guidelines. And as I already said, as Sanjeevani said, that yes, there was a training schedule in previous MBBS days when third-year students are asked to go to emergency, to have dressings, suturing, IV line. Now NMC has adopted a different attitude and system. That is also not invalid. That is also a good way of treating, because in our setup we start experiment on human being by puncturing. That is not allowed in Western countries. You have to learn this technique. You have to do the first surgery on a simulator, not on human being. So this simulator-based training is made mandatory for all students. And if you find this simulator-based training, it is a very expensive proposition. You have to purchase mannequin, buy a lot of things. Not all medical colleges has that come up. 5 years gone down the line till the new regulation came in. Not all medical colleges are equipped with a good simulator-based training center. Then Dr. Hajra said, in MBBS course, in our MBBS, what was there? Study, exam, leave, then internship. No. If you go to Western countries, all medical teaching has got a period known as elective. And the proposal was to have a 12 weeks intercalate for diverse learning, where students can choose anything. You can choose literature. And NMC has given a provision that you can choose homeopathy. You can choose some form from Ayush to learn what is happening there. So 12 weeks. And this proposition, although proposed black and white, has not been yet implemented in all medical colleges. This family adoption, I don't know the last order yesterday, but the family adoption was a program made 5 years back. And if you go into the depth, it's not a bad idea to have this sort of family adoption program. This gives you a leadership. You go to the village, the first question is not what is your income. The first question is, I am a medical student, I can help you when you are in distress, I can communicate your health needs to the next level of things. And the program was, each student will go to each family. He will maintain a register. He was supposed to adopt 5 families. And he will be the first point of contact. If you can assure that a family can ring you up saying that my daughter has got fever, my family has this problem, and it is this boy who will arrange, will give the first-hand advice to this family. That was the idea of family adoption program. And once you get acquainted, if they feel, yes, this boy is dependable, they'll give you everything. Yes, yeah, 1 minute. And then another part of this new training was the new age doctor should be tech savvy. The age of artificial intelligence. The medical field is now invaded by artificial intelligence. So it was part of your training that we should make our students exposed to this artificial intelligence. Central government has created a digital platform where student can learn, can enter into the digital platform and learn on his own. This important part, compulsory rotating internship training. A lot of emphasis and seriousness given to this period of training, because here you learn the nuances of your entry into the practice. But what is the current situation? Current situation is they are busy with their PG NEET exam. They are not bothered about what is going in internship. Another important part of new training was having adequate clinical materials in the medical colleges. I can assure you there is no dearth of clinical material in government medical colleges. I have visited large number of medical colleges in private sector. You need clinical material? Yes, that is there. Where? In the computer. At morning 9 o'clock, 1500 names are entered in the computer, imaginary names. Out of these 1500, 300 goes to medicine, 300 goes to surgery. So they are all entered. These are for NMC. NMC in paper will see that this medical college has 1500 entry in the morning, but these are all in papers. But still these had not been addressed, even with good MCA inspection. And next exam, I can assure you, if this exam is done properly, 50% students will get stuck. They cannot go, even after clearing university exam, they will not get license to have internship. They will not have license to get registration unless they clear next. But if you go to this NEET UG, NEET PG exam, 50% was the baseline to get entry. But so many seats in medical colleges getting vacant, the marks are getting reduced. And we see the newspaper last week, you'll find that securing even 15%, 15 out of 100, that boy is made eligible to get into a medical college. And if the next is like that, again, the marks will go down. So ultimately, the quality will be at stake. Thank you.
Dr. Dubey, we have overshot by 3 minutes. So can we have 6-7 minutes more? Is it possible? I just want to engage the panelists. Thank you very much, Professor Shah. So the take home is that, yes, there was a need for a change. Two, NMC has tried and is still trying to introduce good changes, but as we have already heard from Dr. Saurabh Ghosh and Professor Shah, that all that glitters is not gold. I'll just engage two things. In this conference today, we had a galaxy of speakers speaking before us. They were all from private hospitals. Why can't like I'm in a private hospital, but I think I'm a good teacher. Why can't NMC think of engaging us in teaching? Professor Saurabh Ghosh, Professor Hajra, 1 minute each. Why wouldn't you allow me to go and teach?
I'll just give you a bit of that. First of all, thank you, Professor Shah, for elaborating the current curriculum. Let me pick and choose 1 or 2 points on that. The first batch appearing for NEXT was admitted in 2019, before COVID. And they are supposed to appear in NEXT at the end of 2023 or the beginning of 2024. They have completed 4 years of their training, right? Forget about the students and the teachers. NMC doesn't know how it is going to take next. It has not yet notified what will be the structure of the examination. Now, if the student fails, the onus lies with NMC, not with the students. They have all qualified NEET and come to study MBBS. Just before your exam night, you are being provided with the information that this will be the scenario of your examination. Have you ever heard of that?
Agree.
When you are introducing a course, at least 5 years down the line, on the back side, you should have thought of what will be next examination like B. And you notify that. Whoever is interested in medical education will come, who is not interested will not come.
But yeah, but just for
Right.
a second.
Similarly, in teaching, we are jumping for changes. I'm giving you an example. Previously, a medical faculty, after 8 years of teaching experience, was supposed to be a postgraduate teacher. It has been just pulled down to 5 years, right? They have never noticed what is the who can become a UG examiner and all this. That is still the previous notification is in vogue. After 4 years, you become a UG examiner, but after 5 years of teaching experience, you become a PG examiner. What about the PG teacher? Sorry, not PG examiner. Previously, you could have been an internal examiner in postgraduate after your first batch passes out, that is after 11 years of your teaching experience. We have brought down the experience to 5 years, but we have not mentioned anything about the internal examiners. There is no thinking process as I can feel. If you take my personal opinion, the people who, there was a severe gap, at one point of time, the majority of the doctors, they opted for private practice without going to medical education. In we have seen in our teachers, the best of the students, the cream of the students, they used to be in medical education. Subsequently, there was a time, because of various reasons, the doctors preferred to be out of medical education, in the medical private practice. There are a lot of people in private practice who are excellent teachers. But there is no formal, you cannot elaborate their experience in teaching in a formal way, so you cannot induct them over there. But there are, there are scopes for visiting faculties and all these things. But well, there will be a tremendous mismatch. We are aiming to have barefoot doctors who will treat people in the villages, and we are talking about tech-savvy people coming out of the medical colleges.
Okay,
So there is a mismatch.
Okay, I'll just stop you there for just 1 minute. All four of you at least, from Professor Mitro, Professor Hajra, Professor Shah, you have interactions with NMC, right? I'm giving you an example of what is currently happening in the UK. A consultant or a senior or a registrar who was not involved in medical teaching but interested to teach, they are allowed to come in and take an hour of teaching session, and they are rated by the students. And this rating is going into a central computer. So why can't you, please,
if you
Professor
get
Hajra.
45 students in the class out of 250,
Yeah,
who is
Professor
going
Hajra,
to...
Just to address your question, there is no bar in principle. NMC has never said that someone who is in private domain or somewhere else cannot take classes. They have left the policy to respective governments and universities. There's a system of emeritus professors in many states of the country. Even in West Bengal, the government earlier was allergic to involving people from the private sector in teaching, but now that bar is gone. People are being employed as specialists on contract, and they can get involved in teaching. Okay. The only thing the NMC has put a bar on that, you cannot give them a faculty position straight away to associate professor or professor.
Okay,
If you are giving them a faculty position, it has to start with assistant professor.
So that comes, just 1 more minute, because we are overshooting time. I'll start this off with this question to Professor Mitro, but it will go to everybody. Is the NMC, with all this, is the NMC trying to introduce a kind of mixopathy subtly as well? Why are we talking of Ayush and Ayurveda in mainstream medicine?
No, just in one word, if I can say it is not a mixopathy. What is the background idea, I don't know, but how they have introduced, they have told that in the elective subject,
What Professor Shah said. Okay.
Yes, you can take this to have a taste of that. Experience of the other streams also. There is no doubt. My one point, at the time is very short, just I want to comment of all this, because I was in the committee did an MCI, not in NMC, but I proposed this visiting faculty for a long way back. But only thing that it can improve in the NMC structure also, if they can take, as Saurabh has pointed out a little bit of it, that if they can take for the undergraduate, basic doctor preparation, those doctors or those teachers who have got vast experience in the undergraduate teaching. Problem is that they are taking them, some of the doctors also, they are very known, well-known doctor maybe, but they have no contact with the students and undergraduate teaching. Okay. So that may improve that situation.
Okay. Your take on other pathies? I mean,
Yes,
But-
there is a background. You can, if you see the NMC notification time to time, there is a background of imbibing other pathy people into the modern medicine by training them for few years, few months. So there is a background agenda that other pathy should be with the modern medicine. There is.
well, that's a tragedy. But anyway, we don't have the time to discuss on this further. Yes,
Just,
you'll have to wind up.
I am
Yeah.
pretty ignorant of the fact. Can you enlighten me? How many of these pathies came into play during the COVID-19?
Well, none. Except yoga, none
Amar-
of these pathies have a scientific basis. That's proven.
Only thing that comes to my mind is Sukumar Rai. হাসছিল সজারু ব্যাকরণ মানি না হয়ে গেল হাঁসজারু কেমন এটা জানি
Great. With that, ladies and gentlemen, we come to the end of this panel discussion. Just one question to our student, Dr. Sanjeevani Hajra. If today you were given a second chance, would you choose an IIT or a medical college?
I wouldn't choose an IIT, I'm sure of that, because I got an IIT seat, but I left it.
And you're happy about that? Great.
And I'm happy about that.
For your
Thank you very
information,
much, ladies and gentlemen. Thanks
Doctor,
to all the
for your
panelists.
information,
Yeah,
IIT Kharagpur is going to start a medical college.
yeah.
And Indian Institute of Science, Bangalore is going to start a exclusively postgraduate medical college based on
I'm
research.
very involved with the School of Medical Science and Technology in IIT Kharagpur. So, yeah, that's welcome.
But no
Thanks
medical
to
college is going to start an IIT. We are not interested.
Okay, thanks to all the panelists and thanks to ladies and gentlemen.
So, thank you, Krishnendu, and all the learned panelists for excellent discussion we have regarding this medical education, future of medical education in our country. Now, I request our Association Secretary, Dr. S.P. Rai, and Dr. Vice President, Dr. Parso Sati Sengupta, to felicitate all the panelists and moderator. Let me start, Guru.
We have overshot by about 15 minutes. কয়েকটা জিনিস মানুষের সারাদিন মনে রাখে তোমার ব্যাপারে কোনো জিনিসই মনে রাখো আজকে তুমি আমাকে ফোন করে একটা ওরেশন দিয়েছিলে এসআই তুমি আমাকে ফোন করেছিলে আমার ছেলে